Society Town Hall. And we appreciate you being here tonight. We have a very interesting and timely topic to discuss this evening with our presenter, lecturer, Mr. David Bynes. Mr. Bynes serves as an associate director with the Center for Inclusion, Diversity, Education, and Advocacy at Florida Atlantic University, where he has primary responsibility for diversity, equity, inclusion, and justice education initiatives and training. He also oversees the newly launched Office of Black Student Success and Initiatives. Mr. Bynes is also the founder of Destiny Speaks Coaching and Consulting, a personal and professional growth and development agency. He is currently pursuing his Doctor of Philosophy in Curriculum and Instruction through the College of Education in the Department of Curriculum, Culture, and Educational Inquiry at Florida Atlantic University. He has received training and or certifications through organizations such as the Racial Equity Institute, Social Justice Training Institute, Anti-Defamation League Train the Trainer, and National Conference of Race and Ethnicity. His personal mantra is liberate minds, liberate people, and through his scholarship and activism, he helps to assist individuals in connecting with their authentic self and creating meaningful and transformative lived experiences that will lead to a more just world. So with all of that education and experience, I present to you Mr. David Bynes.
All right. Kelly, thank you so much. And thank you for the invite to be with you all tonight. I was sharing with Mindy that I was nervous because I was like, this is out of my element, but it's awesome to be with you all. And I certainly want to pause and thank Dr. Colette Brown-Graham for the recommendation. So I'm gonna go ahead and jump in tonight. I know time is limited. Thank you all for being on tonight as well. And so we want to talk about from this theme, do no harm, advancing abolitionism and racial equity in healthcare. And we'll break that down as we go along. And so for me, first of all, I want to greet you all in the Zulu word, Sawubona, which simply means I see you. And the response to that would be that we see each other, right? And so again, thank you all for being here on this evening. And so you heard a little bit about my bio. So I'll breeze through this, but I always like to let people know who I am. And I was always trained to let folks that you're talking to see the credibility and the work that you've put in, you know, and to give them some sense of calm that you might know a little bit about what you're talking about. So, so you can see, again, a PhD student in curriculum and instruction, but I'm also right now doing some work with Palm Beach County through the community partners of South Florida, where I serve as a dialogue for to change facilitator, as well as I serve on the racial equity core team for the Birth to 22 project. And I'm also involved with organizing against racism, the Palm Beach Alliance. And so it's awesome to be here and to be able to share some of that information with you. Before I start my presentations talks, I like to do an land acknowledgement, and I do it from this space since I'm here in my office. I'll do it based upon being in Florida Atlantic or at Florida Atlantic University, which is also, of course, located in Palm Beach County. So we could flip-flop that literally, but the land acknowledgement is that we simply understand that Florida Atlantic University or Palm Beach County is located on unceded homeland territory of the Yaga and the Hobe tribe people and tribes which live between present-day Indian River and southern Palm Beach counties. And I simply like to acknowledge and honor the enduring and existing relationship between the indigenous First Nations people and their traditional homelands and territories, which have been colonized and that we now call the United States. Right. And so this idea of do no harm, for me, comes from a Taoist perspective, right? And I know and understand that it also comes from the Hippocratic Oath. And so for me, as we begin to move, and when we take time to really look at where we are in our society right now, I think this is very fitting, right? And so for me, then, what do we mean by do no harm, right? And how do we begin to move forward in terms of looking at healthcare and medicine as an institution or as a system? And so for me, when I thought about what I would talk about, it was this idea of how do we begin to look at our systems, right, and begin to really assess, and those things that are not performing at the highest good of our patients, right? How do we begin to abolish those and then begin to rebuild those? And we'll talk a little bit more about what that actually means. And then this idea of racial equity, right? And so I didn't come tonight to talk numbers, because I'm sure you all in the various spaces in your profession, I know that you know the numbers, right? And the stats, you know, even though the inequities. And so I didn't come to focus on that as much per se, but I did come to talk about what does it mean to have racial equity, right? In healthcare or in medicine. And so we want to be sure to pull that out tonight as we look to some of these disparities that we have in existing. And so whenever it is that I think about diversity, equity, inclusion, and justice from a space of healthcare or medicine, I usually start here, right, with J. Marion Sims. And so for me, knowing that he is considered by many to be the father, if you will, of modern gynecology. And so for me with Dr. Sims, it would be, the question for me would be, to what extent does his historical practices, right, still inform, you know, current medicine practices? And I think this is a great place to start as we begin to kind of build upon this idea of why abolition, and then how is it that we reach a place or space of racial equity. And so again, I'm sure many of you know the story, but here, according to a study published in Proceedings of the National Academies of Science in 2016, here's my frame of reference, right, in terms of what I believe that as we look at the historical narrative, that we fast forward and we begin to see some of these statistics, right? So half of training surveyed held one or more false beliefs, right? Particularly about Black patients. 40% of first and second year medical students endorse the belief that people's skin is thicker than white people's. And then the final one here is that trainees still believe that Black people are not as sensitive to pain as white people, and were less likely to treat Black people's pain appropriately, right? And so we pause there to really take that in, right? And as we begin to look at, again, this idea of abolition, and so the question for me becomes, what are those practices that we clearly need to be examining, right? And so, as we talk about training, right, and talk about med students, or we talk about even still being in the profession, what are the practices, what are the skills, what are the areas of development that we are still paying critical attention to that will allow us now to move forth, that would help us create equitable practices and provide equitable space to all of our patients, right? Another place of foundation, and I start here with foundation because I think for me, historical reference and historical frame of reference is critically important, right? And so it's history, and I tell people all the time, this is history, this is education, and that the history of our country is not pretty, right? But nevertheless, it's our history. And then we have to figure out, what are we going to do with it? And so one of my favorite scholars that I love to study is a gentleman by the name of Resmaa Menakem. And so Resma says this, right, in terms of a foundation. He says the white body is the supreme standard by which all bodies, humanity shall be measured, right? And so when I think about that, and I think about that idea of standard, and so I began to ask the question, whenever I visit the doctor's office, right, can my doctor, and I've gone through this with my doctor, can my doctor see me for who I am, or am I being based upon, is my health and well-being being based upon a standard that may not be able to tell my whole story? And so I absolutely believe that we must be in spaces and in position where it is that we are culturally competent enough that we are able to understand, right, the story of our individual patients. And so then what is white body supremacy? According to Mr. Minicum, white body supremacy, again, not necessarily having anything to do with white people per se, or white identifying people, but white body supremacy is more of a system, right? And so it's the individual and institutional attitudes, practices, and policies that would elevate white bodies as the standard, right, from which we shall measure as a society. And so let me say off the bat, you don't have to be a white identifying person to identify here, right? There are plenty of people of color that can still lift up that particular standard, right? The white body supremacy is first described in the writings of Resma Minicum as a type of embodied trauma response, right? Resulting from the intergenerational transmission of oppressive race-based biases and fears held in the body. And so Resma talks to us about this idea of embodying, right? In fact, he goes on to say that if we're really going to move into this idea of racial equity and racial healing and trauma healing, that it's gonna have to come from an embodied space. We spent a lot of time trying to really think this issue away, if you will. And so we talk about this from a cognitive perspective, and we think, right? We get into conversations like this, or what I do on a regular basis, right? We have all these one-off kind of trainings, and we think that, you know, by gaining the knowledge, reading the book, right, that that's going to be enough eventually to help us get over this hump of moving beyond the inequities, right, that we often encounter. What Resma Minicum now says is that we have to really put in work, right? We have to begin to get with other people, right, that often identify the same way that we do, and we have to begin to have these conversations, or as he would say, we have to put in these reps. And so if we're gonna move beyond this idea of white body supremacy, right, very much same concept as white supremacy, if we're gonna move beyond that, we have to get into this idea of working together and really having these conversations where we not just build strategy, but we begin to build culture, right, around how to attack this particular problem or issue. And so he says that this is a construct, right, that's grounded in the belief that the reflective responses that sustain racism are often unconscious and manifest, right? And so for a large part of this is really not even malicious. A lot of it is moving from the individual stance into the systematic, right? Or the systemic. And so it's there because it's so embedded within our society. I'll never forget that I went to a conference, and one of the speakers at a conference said to me, or said in their talk, that, you know, we could, everyone could stop being racist, right? And we still have racism. And that stuck with me. And so later on in the conference, I found that speaker and had a personal conversation. And I began to ask, you know, what did you mean by that? And that speaker began to help me to understand that there are things, there are oppressive measures that are so embedded in our society, right, that even if the individual behavior stopped, you would probably still have these ideas of whatever we call the isms, right? Racism, sexism, homophobia, right? Religious bigotry, etc. Because those things are so embedded in our system, we often now find ourselves functioning right through those systems. Therefore, we're functioning in many of those, or should I say, carrying out many of those oppressions. And so RESMA challenges the idea that such deeply embedded patterns can be transformed through cognitive processes, or cannot be transformed through cognitive processes alone, but rather must be addressed somatically, right? And so this is that idea that we begin to do the work in the body. And so what happens, right, when we encounter? We have basically 4 things that we do. One is to perpetuate, right, this idea of white body supremacy, right? Secondly, it is to really begin to interrogate the pain of white body supremacy that can be broken down into clean pain and dirty pain. We'll talk about it in a second. And then this idea that we begin to actually practice dismantling, right, white body supremacy. And then 4th, this idea that there's a precision to our healing from white body supremacy. This is the idea that we want to begin to not just have conversation, but to literally do the work to move from race to culture to creation, right? This is the idea that we really want to be able to see every being in their humanity, right? We want to eventually begin to move out of this conversation about race or this racial construct. And now we have to move into this idea of understanding what culture really is, right? Whether it's, again, racial culture, whether it's ethnicity, and then even from there, still moving beyond that, right? The premise of seeing the physical being to even moving down, I would say, to the soul, right? But this idea of creation. And so it's this idea of how we now begin to humanize everyone that we see, right? And we see them for who they are. And so what is clean pain? Clean pain is this idea that, number one, clean pain hurts, right? Clean pain is this idea that we're going to really sit in, right, our own pain. We're going to sit in the historical narrative as it has been, and we're going to sit in it because it's in that pain that we really begin to come up with the various constructs, if you will, or different ways that we now need to approach this, right? We come up with the ideas of how to mend, right, our own capacity for growth. And so even as medical professionals, right, this work begins with you and how it is that you are even processing where you are, right, in this conversation and in your practice as it relates to being a practitioner or equitable practitioner, right? And so this idea to grow is you're going to go through some pain, right? And yes, it hurts, but it also enables us to engage our own integrity and to mend our own trauma, right? And so again, we get to sit in it, think about where it is that we've come from. And I often ask people to think about it from this perspective. Who have I been? Who am I now? And who am I becoming, right? Who have I been? Who am I now? And who am I becoming? I'm beginning to really sit deeply in those questions around self and the evolution of self, right? Clean pain allows white Americans to confront their collective disassociation and silence. Oftentimes, this is not a conversation we want to have, right? And so oftentimes that silence is there, that silence is deadening, and it's that silence that we're trying to move beyond. And then finally, clean pain allows BIPOC or Black, Indigenous, people of color folks to really confront internalization, right? Defectiveness and self-hate, or in short, it allows us to begin to really confront and internalize oppression versus this idea of dirty pain, right? And so dirty pain is when we respond from our most wounded parts, right? We've done no work, but we respond from the wounded parts. We become cruel or violent, or we just simply run away from it, right? It looks like avoidance and blame. We now begin to choose silence, out of fear, rather than trying to really dig in and do the work. rather than have those hard conversations, right, we begin to turn and go the other way. And so this is important because even as we, again, think about this from the perspective of healthcare and the work of medicine, we often have to do the hard work of figuring out, where have I come from, right? How have I been socialized? I deal with this concept called the cycle of socialization versus the cycle of liberation. And oftentimes we don't recognize that unless certain thoughts and habits or practices and behaviors have been allowed to be disrupted, we have not come into the space of full liberation where we get a chance to think for ourselves. A lot of times we're still thinking and functioning based on how we've been socialized, right, from the earlier parts of our upbringing. And so this becomes critically important for us because as we begin to interact and associate with folks of difference, we then have to be able to be in that space where we not only embrace, right, difference, but we now begin to learn how it is that we come into true relationship with people of difference or who identify differently than us, right? And so this idea then, because it's through our healing, right, that we can now begin to talk about forward progress. And this idea that healing can be uncomfortable, right? But Minicum reminds us that the refusal to heal is always more painful, right? He invites us all, no matter what our racial identity is, to mend the trauma in our bodies. And so we want to keep that in mind, right? And so where do we start? We start with this idea of asking, do I really know what it means to be culturally competent, right? Do I know what it is to have awareness of other cultures, right? Do I know what it means to check my attitude as it relates to other cultures or people that identify different than what I may identify as, right? Do I understand what it really means now to how to go out and search for the information that I may not possess at this current time? And then a fourth component of true cultural competence would be this idea of skill, right? Do I now know how to put all of that information that I do have, right? I've read the books, I've gone to the conferences, I've sat in the dialogues, right? I've been in the meetings where we've talked about different practices, and we've talked about how things relate to patients of various cultures, right? And so I've been there, but have I now really developed the skill set to put that into practice? And so this idea of cultural competence then really begins to help us understand what it means to be in the knowing of someone else's background. And as I said, also beginning to check the attitude in which I bring to the table. The other piece that intersections with that is this idea of cultural humility. And one of the things that we see is that to the larger degree of our cultural competence, we will also see our cultural humility functioning hand in hand, right? That simply means I'm willing to do the work, right? I'm willing to put in the time for critical self-reflection. I am willing, right, again, to check my own attitude. I'm willing to build relationships wherein I am able to go to individuals, again, that are different than me and begin to have those critical conversations wherein that I am now asking and seeking the feedback of how it is that I should be performing, right? Critical humility also has us functioning from a base, right, of love and passion and empathy, right, and equality and equity. And so this idea of cultural competence intertwined with cultural humility is where this begins to start, right? In terms of, do I now assess my practice? And if I am assessing my practice, right, and where I am in the profession, it is now, right, that I come to a space of understanding how to effectively work with people of difference, right? How it is that I now begin to address these inequities, right, and inequalities that I'm seeing, because we know that they're there. Oftentimes they're not addressed because either A, we won't talk about them, right? Or B, we simply choose, right, to see, we simply choose not to see it as a problem or as an inequity, right? And so, but we want to, again, begin to figure out how do we make advancements, right, within the healthcare profession and within the practice of medicine. And so this idea, the journey toward racial healing requires that we see diversity, equity, inclusion work as spiritual, which is why I started off with this idea of do no harm, right? That we sat in it and asked the question, what does that really mean? What does it mean for me to be in a space, right, where I'm in a profession where obviously, right, I've gotten into this profession not to hurt people, not to do harm, but what is it now that I still need to be aware of that's within me, or that is being exhibited within my practice that now I may have to think about that may be causing harm even in a non-malicious space. And one of the things I ask folks to do is then to sit with this and ask the question, where do I fall on this continuum? Because where I fall can also have a direct impact and have direct indication as to how I function in my practice, right? I'm not going to stay here long, but I like for people to be able to really sit in this and begin to ask themselves that critical question, who am I? Second critical question, where do I fall? Right? And a third critical question that I ask of folks usually when I do trainings is this idea of how do I want to show up, right? How do I want to be seen? Whether it's in my practice, whether it's in relationship, right? Whether it's in the grocery store. So what do I mean by abolitionism, right? So for me, abolitionism, and I'll give you a few points here, invokes this idea of a gentleman by the name of W.E.B. Du Bois from 1935, this idea of abolition democracy, in which he says, you know, this idea is now based on breaking down systems, right? So we don't get away from that, right? This idea of abolition, abolish, right? But I want to assure you that I'm not saying, as you know, many have said with abolish the police, that we just don't need police, right? Or we don't need healthcare professionals. But what I am saying is that in this space, we want to now begin to understand what does it mean to break down a system and then to build up a new, healthier, and more just system or society, right? In other words, what does it mean now to get rid of what we have now and to begin to think about, right, or reimagine a system or a society that really does incorporate everyone that it's supposed to benefit, right? As we know that many of the practices and policies, right, and procedures that we still function with today came at a time where everybody wasn't considered, right, worthy, I'll say. And so we have to begin to think about this idea of abolitionism, right? I believe that every system, every institution, right, that we have that comes together to make up the United States, I believe that we're in such a place that those systems and institutions are going to have their own day of reckoning, right? For me, that means that they're going to have to come to the table and really sit and question, right, the very foundation of the very practice, right? They're going to have to come together and really have some critical analysis around, are we serving, right, our patients? Are we serving humanity in the best possible way that we can? And so this idea of abolition then comes right out of this idea that that's championed by some activists and scholars like Angela Davis, right? Miriam Kaba, who has an awesome book out right now called Until We Get Free. And so they've argued, right, that this idea of the abolition of slavery was not about a one-step process, but it's ongoing. It's an ongoing critique of the system. It's an ongoing critique of the very world that we live in. Abolitionists would even go on to say that this idea of abolitionism is where true education resides, right? Because true education teaches one to be critical about the world in which they live, right? And so it is there. That James Baldwin would say this. He says that I so love America, right, that I reserve the right to critique her because I love her, right? And so whatever it is that we love, right, whether it be the country in which we live, whether it's the profession that we are performing in, we ought to reserve the right to be critical of those things, because it's in that criticality or the critical analysis that we now begin to find new emerging ways in which to function, right? And so just like abolitionists are now looking at this idea of what does it mean to have an effective policing system? What does it mean, right, to look at this idea of surveillance and mass incarceration? And so now some of them are even asking the question, should we now also then be looking at the abolition of medicine, right, and healthcare? Should we be looking at the criticality of the system, right, trying to figure out what is happening within the system, and then finally looking at how do we begin to build a new system, right, that removes as much as possible, right, begins to remove these inequities that we face. This idea of abolition in healthcare and medicine is to interrogate the upstream structures that enable downstream violence, right? And so just like with police brutality, that there are some instances in which we know that there are covert inequities that are still happening. Abolition means that we have to challenge race-based diagnostic tools and treatment guidelines that reinforce antiquated and scientifically inaccurate notions of biological race, right? It also means that we have to be integrating longitudinal anti-racist training into medical education. And so again, now we get into the depths of how do we begin to see the person that walks through the door, right? Are we functioning from a space of bias, right, that has possibly come up through our own socialization, right? And then we've not challenged that bias. And so over time, that bias begins, right, to evolve into different things, prejudice, discrimination, right, on into the isms. And so we have to now take a step back, and we have to begin to understand the history of racism, even in medicine, which is why I start out. And I know that we can go back even further than that, but for me, I usually start out with J. Marion Sims, right, as an indication to begin to really understand why it is that Black people and other people of color, right, may be apprehensive about doctors, right, about healthcare, why it is that there may be so many questions even right now around, the vaccine, right, and this idea that has come up, right, I'll say it, in terms of this idea of those that are vaccinated versus those that are not, right, and why it is that, particularly within the Black community, it is so hard to get those numbers up, right, and to get many of them to our Black identified individuals to really begin to trust in the system that is saying that it is looking out for the best interest. Well, history will begin to show us, right, that there are some things there that causes folks to be very cautious, right? There are these racial health disparities that causes one to really be cautious. And so we still have to be actively recruiting and retaining and supporting, right, Black and other minoritized faculty and staff and students, right? And so this idea that representation is critical, right? And then finally, I would say about abolitionism, in terms of what it is and how it plays out, is that it is this idea that practicing abolition in healthcare and medicine entails health workers joining the national conversations about police abolition and using their social power to reinvest in programs that build community and capacity, even for mental health care, youth development, education, and employment, as well as harm reduction, right, efforts. And so the whole premise of why we are here is to come into this space now that we want to cause, again, as little harm as possible. So this whole idea about abolitionism and advancing it is that we begin to reimagine and recreate systems that are functioned on harm reduction. And for time's sake, I'll go through these really quick. And then when we talk about advancing this idea of racial equity, right? Racial equity, how do we begin to do that? Again, I didn't come to really blow you away with things that you may not already be doing, may not already know. But a lot of this is in my findings, right? In terms of how do we now begin to advance? If we were to do these things effectively, right? What would the system then begin to look like? And so this idea then of collecting, right, data, right? And based on race, based on ethnicity, right? Based on gender. Some would even say based on class, right? Because we know that those intersectionalities right there, that when we begin to look at what are the leading causes, right, of inequities, we know that race is the leading category. Not that, you know, folks that are LGBTQ plus don't go through things when they go, right? But we know that through data, we know that the leading cause, right, of these inequities usually come out to be race. And what I often also tell people is we have to then begin to look at the intersectionality oftentimes, in particular of race, ethnicity, and gender, right? And again, I would throw class in there. And if it's known, we also then need to begin to look at it from a space of sexual orientation, right? Because all those come into play when we begin to do the study around the inequities within the healthcare system. Secondly, I would say that we have to identify and address the biases, right? And so we've talked about that a lot. And the question there is, what is being done to bring self-awareness and self-examination to the individual bias, right? Because we know, again, unchecked individual bias essentially rolls right into systemic, right, bias or bias that's embedded within the system. Thirdly, in terms of advancing racial equity, is this idea of establishing educational and ongoing developmental opportunities. I cannot stress enough how this cannot be a one-off. These conversations, no matter how hard they cannot be a one-off. These are conversations that have to be done on a continual basis in a variety of formats, right? Getting on a Zoom call, right, and having someone talk at you is not the only way to practice this. And so, but there needs to be some ongoing educational and developmental opportunities because that directly then helps us to begin to remove individual discretion, right? Because now we begin to sit and we're talking and all of a sudden now we're kind of looking at what are the kind of clinical guidelines that we're using, how does that apply, right, to this particular people population, if you will, right? What are the standardized checklists and what are just the overall protocols that we are using and how could we begin to look at that differently? And then finally, there needs to be this idea of a continued search for objective measures of care and practice, right? In other words, how does the practice move beyond the provider's interpretation of a patient's report, right? How is it that we begin to understand the critical need for representation, right? And begin to really function in that area, right? Where patients are comfortable. And now the doctors and other healthcare providers really get a chance to know and understand their patients, right? And so we begin to create, again, these spaces of equity, right? Where there is fairness, where there is clear access, right? And so people can feel comfortable knowing that they're coming and literally they're getting the best care that they finally can. And how do we do this, right? This is a theory that's been developed by a scholar, comes out of the education world, but I thought it was fitting here, right? In terms of how do we do no harm, right? how do we begin to look at who we serve and who we're called to protect, right, as practitioners within the field. And so Yolanda Seeley Ruiz says this idea of the archaeology of self, right, and that it goes bottom up in this pyramid, but she begins to look at this idea from critical love, right, to critical humility. And all of this is looking at self. What is the love in which I now move, right? And I approach my practice and each and every patient that I am with or that walks through the door, right? This idea of critical humility and how it is that I now begin to understand the limits of my own worldview and what it is I need to do to be open, right, to the worldviews of other folks. That leads me into this idea of critical reflection, where I actually sit and take time to think about who I am, right, and how I'm functioning in the world. But I'm also getting the historical literacy, right? I'm going back and I'm challenging myself to go beyond spaces, right, of where I've been in terms of my own knowledge. And then the big part, the critical piece here is this: how do I begin to really dig into self, right? How it is, as she calls it, how do I begin to look at this idea of excavating, and I would say excavating the soul, right? How it is that I'm going in, digging up, right, getting healed from my own traumas so that that doesn't eventually, right, evolve into my own work. And then finally, once we've been able to do that, this idea of interruption, right? If we are in a space where we're not functioning at our highest good, that can now be interrupted, right? Because we're now doing the work. And finally, I would say on this front of doing the work and this idea of love, one of my favorite revolutionaries, Che Guevara, would say this, that the true revolutionary is guided by great feelings of love. And so I say to you all today that I consider you to be great revolutionaries, right? I consider you all to be the great and some of the greatest innovators that we have on the face of the planet. But I also consider you all to be very vital, right? Not just to your work, but very vital to the success, right? And the ongoing advancement of our society. And so to you, I say thank you for all that you do on a daily basis. And I say thank you. And I ask that you continue to move in the spirit of love as you move throughout your work. And again, thank you all so much for having me this evening.
Thank you very much. That was very compelling vocabulary and concepts, and a really very thought-provoking presentation. I'm going to give everyone a few minutes if we have some questions. I don't see any questions in the chat. So maybe Taylor, I don't know if you do, but I'd like to open it up if anyone has any questions for Mr. Bynes on the topic, or have any comments that they'd like to make. Feel free to unmute yourself. Dr. Duncan, president of the society and a strong member of the C. Lee Rory Jefferson Medical Society. I'm sure that this is not necessarily new information to many of you, but certainly very timely and a great conversation for all of us to have. So from Dr. Lowe, the question is, how do you have this discussion without evoking defense mechanism in most folks? Great question, Dr. Lowe.
Yeah, Dr. Thank you for the question. I think it's hard. And so in terms of evoking, I think one of the things we have to get used to is that when we begin to do the work, it's going to evoke different mechanisms, right? Whether it's defensiveness, whether it's silence. And so you have to now begin to look at this from a space that that's why it has to be an ongoing conversation. And you don't come out of the bat, right, and so to speak, hit someone over the head, right, with the, something that's out in left field, so to speak. But you start wherever you think that person is, right? You give them bits and pieces that is palatable to them, that they can kind of chew on. And so I would say that oftentimes there are a plethora of resources that are out there, but you begin to talk about the historical factor, right? You begin to ask them to take their own self-inventory about where they are, right? And so the more they, individuals can feel like they're part of that process and they're part of guiding that process, right? Then that can play a major part, right, in challenging, that defensiveness. But it ultimately, it's going to be there because, again, this tends to be a conversation that no one really likes to have, because it challenges us to look at our individual selves, but it also challenges us to look at our families and how we've grown up, right? Those ideologies. But again, enough of these conversations and dialogues, eventually breakthrough will begin to happen.
Hi there. Yeah, thanks for recognizing me. Yeah, so as everybody probably knows, I'm the 102nd president of the Palm Beach County Medical Society, and happy to be now the first African American to do so. And one of the things that I realized and wanted to champion is just this kind of discussion that we're having today. And I thank you for coming in, enlightening us with, Dr. Lowe. I guess, I started this diversity and inclusion committee so that we could get new doctors, doctors with different perspectives, different backgrounds, so we can make new ideas in how we're going to make medicine better for all practitioners, as well as for our patients too, to bring fresher ideas. As some people may realize, up until like 1964, well, the National Medical Association started back in 1895 because Black folks weren't allowed to join the American Medical Association until 1964, some 60 plus years ago. But it's great and it's powerful that we're having these conversations and that there's so many people here on the call. It's a great start, and but it's a start of a process, as you were saying, and one which I'm sure a lot of my own colleagues and peers that I work with every day would be brought into kicking and screaming, because so many people don't feel that there's a problem. But you can ask a number of the practitioners on the phone, and they see it and feel it, and the patients definitely do on a daily basis. So I thank you for bringing all this information forward to us, and I definitely look forward to a continued dialogue about this. So I thought I read in your background, at FAU is where you're practicing. How many people have you been able to enlighten there, and what have been some of the outcomes?
Sure. So in my role, I work with faculty, staff, and students. So the easy answer would say, I've at least been in front of thousands at this point, right? But in terms of the data, that it's a slow moving process, right? So I know that, for the thousands I've been in front, everyone has not been enlightened. But I will say to you that the data that we collect through our office would say that our campus is moving in the right direction. The number of incidents that we have, again, whether it comes through racial incidents or whether it comes through incidents of deriving out of homophobia, et cetera, are very minimal on our campus. And I like to attribute that to the work that we're doing through these racialized conversations, but also then how the conversations that we're holding around our LGBTQ plus community as well. And so our center is very sought after. We do a great deal of work with our med school and nursing, College of Nursing here on our campus. So I think that's a testament to the work we do as well. And then starting last year, we started to be called on more and more by other areas of faculty. And so for anybody that knows that side, you know that for faculty to call upon you and consider you to be a great resource, that must mean that you're doing something right.
We have two more questions in the chat. Is there a resource list for these concepts and scholars that have been referenced throughout your presentation?
Yes. So what I'll do, I'll compile that resource list. I'll send it over to Mindy. If you like, I can send the PowerPoint as well. I don't have a problem with that either.
Yeah. Wonderful. Thank you. And the last question I see in the chat is how do the medical schools respond to topics like this?
I can only go by our medical schools, one that we've started working with. I've been back at FAU now for 4 years, and we've been working with the med school ever since. And so again, we're working with the med school on everything from looking at admissions criteria. They're having conversations around admissions. We began last spring semester having some conversations around particularly Black men in med school. And so we're matter of fact, just a couple of weeks ago, had a conversation around what are some new initiatives that we can start to look at for some of the surrounding high schools, in addition to the young men that are on campus, to begin looking at med schools. And so they've been very receptive to it, right? As Dr. Duncan talked about, again, I would say it's a slow moving machine. And because of the history of it, you still do have a lot of people in place that may not necessarily understand the reason or the necessity of the transition, right? That it's uncomfortable for them. But I would also say that we are digging in, right? And we're having these conversations nonetheless. And so we get invited back every semester. My colleague who oversees a program that we call the Safe Zone, which is a training around LGBTQ plus issues. She is at the med school every semester, and we train all of the new incoming medical students every year. And so it's been well received. And I won't say there's not been some bumps and bruises and potholes, but nevertheless, we're still moving forward and having the conversations, which I think is a testament to the leadership, in the med school.
Great. Dr. Lowe, do you have a question or a comment? Is your hand up? You are on mute.
Am I on mute now? Can you hear me?
No, you're not. Yes, we can.
You can hear me. Good. Thank you, Dr. Bynes, for this. It's been very excellent. I guess my first question would be, how do you get more people engaged? And you've been saying that it's a slow process and all. And I think I say that because I was a delegate for the FMA, and I had a resolution that I wanted to get through. It was on diversity, equity, and inclusion. I got my resolution in a little late, so they didn't really want to put it in. The body didn't. But believe it or not, the students who do get it, the medical students from the University of Florida, they got their resolution in on time. And guess what happened? It didn't get it put in.
Right.
They had to go back and add it in. So it's just very interesting. But I think the younger people, most of them do get it. I think it's a lot of us older people, and for a number of reasons. And I had stated in my resolution that the American Medical Association back in 2019 said that racism was a public health crisis. And so many people got really upset. And there were physicians who were there. And a lot of them, when the issue came up from the medical students from the University of Florida, and some of us tried to get up and at least have a discussion in the committee, in the reference committee, and discuss it, I could see people who were just really saying, individually, I'm not racist, but as you say, from history, from cultural reasons, there's so many things that are ingrained and we can't even see it. One of the young doctor who was here who's a cardiologist from Boca, she got up and she really opened up her laptop and started giving dates and facts and started talking about the social determinants of what happens in healthcare and how we're able to get good outcomes. And she said, if you want to look at it like that, it is one of the social determinants with cultural things, with age, with gender, with all of those other things. Race is right there at the top. But
Yep.
so many people, once they hear that, they just get turned off and they say, you're not going to accuse me of being racist. They get very defensive, or like you say, they go into denial and said, I'm not going to have this conversation. So it is very, very hard to approach this topic and get good outcomes.
I would agree with you, Dr. Lowe. One of the approaches that we take in my line of work is, and a lot of people don't agree with it, but it's a necessity. And so you'll find whether it's in a community, on a college campus, you'll find this trend of creating what we call caucus groups. Caucus groups, when we do racialized work, we break them up into white identifying folks, Black identifying folks, Hispanic, Latinx, Asian, et cetera, right? And we do that because what we have to understand is that race as a construct has a critical charge to it, right? And the reason why I start out with race, number one, as old Morehouse man would say, I'm a race man, right? But I'm a race man because race is the first construct. So there was no such thing as race until around 1861, right? Before that, right, prior to what's known historically as Bacon's Rebellion in Virginia, everyone was known by where they had come from, right? You had the African, you had the Dutch, et cetera, right? The European, et cetera. But it was after Bacon's Rebellion when, the elite started to understand, if we don't do something to cut out this cross-racial solidarity that's happening at that time between the, I guess I'll say it this way, the low working class European and the Black body, they recognized from their perspective, there was gonna be something majorly wrong, right? And so what we now have even today, right, is once again in 2020, you begin to see hitting the streets these cross-racial bands of solidarity of young people, right? I think something like 26 million, right, across the world, right? And so what happens is that because there's this idea, and this is the intersectionality of it. So you have the race, but you also have class. And so this idea of the caste system, right? Somebody is on top, somebody has to be on bottom. So when you begin to get those intersectionalities happening, the one thing that now comes to mind from the elite folks, at least, is we have to stop this cross-racial solidarity. Policies like yours, or the idea of introducing legislation, right, to certain people, and I'll call them the gatekeepers or the stakeholders, decision makers, right, that they automatically see fear. So where do we have to start? We have to be bold enough to begin to start at the top. Until now, this has been a bottom-up kind of conversation, right? Those of us in the trenches, those of us in the working kind of middle class, we're ready for this conversation, right? Yeah. But now we've got to find a way to engage the stakeholders and gatekeepers and decision makers, because that's where it's going to start.
Where the policy will change. You're right. Absolutely. That's very true. That's very true. Thank you.
Kelly, you're muted.
About that, we're at 6:59. So we have kept it within the hour, which is always our goal. Thank you, Mr. Bynes, for, again, a very compelling presentation. It will be on YouTube. So those of you who are here, feel free to share it with your network. And we will have the materials available at the Palm Beach County Medical Society if you would like to receive them, and we can share that. Thank you so much to everyone for joining us tonight. we will begin our series of town hall meetings again. We'll have one in September and October, and we'll be sure to get you the details of those meetings as well. Everybody have a great night, and thanks for being here.
Thank you,
too,
everyone.
Kelly. Thank you, Mindy, Kelly. Thank you. Great job.
Thank you.
Thank you.
Thank you
Thank
so
you all.
much. Fantastic job.
Thank you so
Really
much, Dr.
good.
Baca.
Thank you,
Okay.
Roger. Thanks.
Okay.
All right.
Great
Bye-bye.
job.
Great
Thank you.
job, everybody.
Okay.
Really
Good
good.
night, everyone.